Okay, so it started out with an HSG to evaluate for fertility. Let's scroll through the acquired images really quick. And then the post. So any thoughts?
Don't see free spillage there, Jonathan.
Correct, yeah. So no free spillage. And then there was this rounded filling defect that was called leiomyoma. And so that prompted, the leiomyoma actually prompted the MR. And so on MRI, scrolling, going from superior to inferior, we have this big leiomyoma here on the right, distorting the endometrium. That corresponds to this filling abnormality here. But then, yeah, the filling defects here at the right and left adnexal regions. Looking at the right adnexum, there are all these thin little septations here. On the left, there are some as well, but it's a little harder to see. And then the ovaries were catching my eye as like, are these touching in the midline? Looking at the T1 pre-contrast on the sagittal, I was wondering about this focus of T1 hyperintensity. It was kind of hard to be confident if it's just a low-lying loop of small bowel or if it's a real finding. So I don't have path confirmation of this, and it's an outside patient, so I don't even have a lot of great clinical information. But I think the lack of, we identified lack of free-flowing contrast at the adnexa, made me start to think, are these, oh gosh, I always have to look up the exact term, the peritubal adhesions. And is that potentially what we're seeing here with these little septations at the adnexa? So I don't know if this will wind up being a case of endometriosis with peritubal adhesions, or if it's prior PID with peritubal adhesions. But I just thought it was a great case, especially for HSG, because a lot of us might not be doing them too routinely. So.
That's very cool. Actually, with those tubes, I was thinking maybe hydrosalpinges. So the MRI is really nice. It shows you they're not tubular. They're actually like conforming to the peritoneal cavity, like more like peritoneal inclusion and, like you said, peritubal adhesions.
Yeah.
And one thing I didn't know before my OBGYNs told me is that if there is a hydrosalpinx, that's an important thing for infertility because the fluid in a hydrosalpinx can actually affect the pregnancy. Oh. So if you see a hydrosalpinx, they end up going and clipping off the tube so that it won't affect the pregnancy.
That's very cool.
Cool. Okay, Anu?
Sure. So the history we received was left flank pain, and it sounded like maybe renal calculus disease. So they came directly to a CT. There was no ultrasound that was available to us. And I'm going to scroll slowly through these axial images and then show you the coronal as well. Shout out if you see anything as I scroll through the axial images.
I feel like there was something in the pancreas.
Yeah.
Excellent, excellent.
Like so that's the transition between an atrophic tail with a dilated duct and like maybe a mass.
Excellent. So that's the key teaching point here. So when this was sent to my queue, it was, the read initial was no renal or ureteric calculi, no hydronephrosis, and then an attending, i.e. picked up this myself, the transition here. So exactly right. You can see that there is almost like a bulbous mass, and then the proximal pancreas looks good, but there is atrophy of the tail. And let me show you the MRCP. So these are the T2 weighted images. You can see there is a mass here, upstream ductal dilation, atrophy of the pancreatic parenchyma there. And then here are the MRCP images showing the same. This is the axial T1 weighted image, and this turned out to be a pancreatic ductal adenocarcinoma. So I was just telling my trainees that you need to give due justice to every single organ, even if especially if it is a non-contrast CT, because left flank pain, I mean, this can manifest in anyhow, right? Pain, and very commonly I've seen pancreatic adenocarcinomas or malignancies present with pain radiating to the back. So it was just a show and tell eye test.
Yeah, I always tell my residents too on diffusion, like on MRI, always look at the pancreas, because those early adenocarcinomas are where you're going to make a difference. And sometimes you don't see it, especially in MR, unless you like look at the diffusion.
So true. And see this?
Yeah.
It's very obvious on diffusion. All right, let me stop sharing.
Okay, so this is the first case. This patient had abdominal pain, and then incidentally, they had this lesion that we saw in the T2 in the right lower quadrant. There's a lot of motion here, but you can see that it looks cystic and it's got some locules in it. Let me see if there's any better. Right here. What do you guys think about this?
I want to see a normal pancreas, appendix somewhere.
Let's see. That's a great thought. And actually, maybe this is oh no, that's not the appendix. I will tell you in the end, this did not arise from the appendix.
Oh, okay. You know,
Was it a
is this going to wind up being like a peritoneal mesothelioma or something like that?
Yes, beautiful, perfect. Usually when I see blobby cystic lesions in the abdomen, something I think about is a lymphangioma, but this one actually has like a lot more septations and locules. So it's actually kind of classic for this thing called a benign peritoneal mesothelioma. It's a misnomer. So it's well, the mesothelioma part sounds very concerning, but it's actually a benign lesion, but the cells, the walls are lined by mesothelium rather than like lymphatic tissue in a lymphangioma. And they do have a high rate of recurrence. So between 25 to 50% will recur. So they do need to be followed, but it is a benign process. So it's just a cool case of that. Let's see if I can show you it wasn't really enhancing, but the the septa will enhance.
Aarti, would you give a differential in this? Like, could this be almost like, I want to say like an echinococcal cyst or a hydatid cyst? Something infectious.
I mean, I think if you're in that endemic population, maybe. But I think now that I've seen several cases of peritoneal mesothelioma, I feel more confident saying this, but I don't know. I might have said that versus lymphangioma. I don't think echinococcus, it doesn't really have like a nice wall to it.
Okay.
Like usually your body, echinococcus, your body tries to like wall. That's why they have the pseudo capsule in the liver and stuff. And echinococcus is more in the lungs and the liver. So yeah, I don't think I would necessarily have brought that up. I guess another thing you're thinking, like we could think about is mucinous deposit, right? Like and it's so near the appendix, maybe that would have been a bit good, like, oh, this could be a ruptured mucinous neoplasm. So I think regardless, it has to be resected. But that would probably be even more common. So, okay, that's that one. This one is a patient who came in with flank pain. And this is what their kidney and perinephric space looked like. Any thoughts?
No trauma?
No history of trauma and no history of renal biopsy.
Okay. Was there an obstructing stone?
Nope, there's no hydro and there's no stone. There's like probably a phlebolith here in the gonadal. Because you were thinking about hemorrhage, right? That's like a good thought. Or is it a forniceal rupture?
Yeah, or an infiltrative neoplasm. Urothelial malignancies, I've seen them cause diffuse infiltration.
Yeah, so I think like we don't really know what's going on in this lower pole here. This was a non-con because of our contrast shortage. Another clue, you're going to get it when I show you this. Oops.
The bones.
Yeah. So this patient actually has a history of myeloma. And so we thought, given history, even though this process actually wasn't here a few months ago, we thought this could be extramedullary plasmacytoma. And another clue is that they also have an enlarging paraspinal soft tissue mass right here. So we brought that up, and they ended up getting an MR. And you can see that this stuff, there's a lot of like kind of evil gray soft tissue here. You can see it much better on the MRI. As far as ruling out that this is not hemorrhage, there was no T1 hyperintensity here. Oops. And then it all demonstrated enhancement. And actually this paraspinal soft tissue also demonstrated delayed enhancement.
Wow, it's enhancing quite avidly.
Yeah. Yeah. So there's just all this, and so it's very aggressive. It actually popped up, all of this developed in the past few months. But some things, the extramedullary plasmacytoma, they love the kidneys, they love the perinephric space, they love the paraspinal tissues, but pretty much they can pop up anywhere. I've seen some in the muscles. So if the patient has myeloma, always just have a low threshold for thinking like, oh, could this be a plasmacytoma? Okay.
This is a good one.
This is my next case. The patient's pelvis look like this. So uterus, these look pretty dark. They look like probably fibroids. And we can see that they're pretty avidly enhancing, maybe a good candidate for a Euphy. But they also had these lymph nodes here. So those large external iliac and some prominent inguinal lymph nodes. And some pelvic sidewall nodes. Any thoughts? How would you read this?
Well, the lymph nodes make me concerned that there may be an underlying leiomyosarcoma component to it.
Okay,
so
that's basically the question here. Like, would you say, you know, there could be a leiomyosarcoma here? I'll show you the uterus again on high resolution T2.
I feel like the external iliac and like the inguinal lymph nodes would be a weird distribution.
Okay. But just looking at the uterus, are you still concerned about a leiomyosarcoma?
They're really T2 dark. Do we have T1? Sorry, is this one T1?
This was T2. This is the
Okay.
T2 high res, and they're very T2 dark. And that's one of the teaching points here is when we talked about that paper last week and like the algorithm for leiomyo versus leiomyosarcoma, one of the big things is like hyperintensity or heterogeneity on the T2. And so when they're this T2 dark, these are almost certainly going to be fibroids. So that's one of the teaching points is like, basically, if you feel like they're super T2 dark, you're confident that they're fibroids, then you can, you know, call them fibroids.
Okay.
However, the other question I have is, can fibroids degenerate into a leiomyosarcoma? Like, would you say like, say, you know, okay. You guys can still hear me, right?
Yeah.
Okay. Could you say like, oh, one of these could have degenerated and that's why we get these lymph nodes?
But even if it degenerates, wouldn't it show heterogeneity within it? It wouldn't continue to be so homogeneous.
Yeah, so there's two teaching points here. One, it shouldn't look dark like this. And two, fibroids don't degenerate into leiomyosarcomas. That is not where leiomyosarcomas come from. They come from a different cell line. So when you could have multiple fibroids and you could have a leiomyosarcoma, but it was not from malignant degeneration of a leiomyoma. Extremely rarely, there are some case reports that have shown like, you know, both coexisting in the same lesion, but vast majority do not come from fibroids. So if you had like a prior scan and they looked like classic fibroids and now you see it degenerating, you don't say that it could be malignant degeneration because that's not how leiomyosarcomas originate. And then the second thing is like what Jonathan said, this distribution for these lymph nodes also wouldn't be typical for a uterine mass. That's more external. So we're thinking like distal, like vaginal, perineal mass, urethral mass. Those are the ones that go to the internal iliac and external iliac lymph nodes. These look pretty big. And so we were concerned actually they could be lymphoma. And they were biopsied and they were basically like a lymphoproliferative process without clonal proliferation. So completely unrelated to the fibroid uterus, but the teaching points I wanted to bring up, like if you see these nodes, but you see classic fibroids, you don't bring up like that there could be malignant degeneration. Does that make sense?
Yeah.
Totally.
Okay. And then one more. Okay. Focus on the gallbladder. I'll show you the coronal in a second.
There are multiple polyps along the wall abutting the liver.
Yeah, good. So we see multiple enhancing polypoid lesions along this. So what would you recommend here?
You know, one thing I've seen is if we have only a non-con, you don't know if these are truly enhancing or these are hyperdense adherent sludge. So is there a non-con component?
There is not a non-con.
These are enhancing indeed, or?
Well, even if they were enhancing, like could polyps enhance? Are you concerned? Like cholesterol polyps can enhance.
Yeah, but these are big and multiple.
Exactly. So we're more concerned about this. Anything else in your differential at this point?
They don't look like they've transgressed the wall of the gallbladder. The adjacent liver looks clean. Does the patient have any malignancy? Because melanoma can go to the gallbladder.
No history of melanoma.
Okay.
And we ended up recommending an MRI.
Okay.
So pause this for 1 second. Okay, so here's my MRI. We can see multiple polypoid lesions kind of carpeting the top of the gallbladder. That word I used specifically to.
Yeah, and T2 dark.
Yeah. Here they are, thickening of the wall, kind of carpeting lesions, multiple kind of polypoid lesions. And they are enhancing between pre and post contrast. So these were also, again, called polyps. The patient had been symptomatic. I think they had some stones. They ended up removing the gallbladder and they did not come back polyps. They also did not come back gallbladder cancer. There's another entity in the gallbladder, anyone know? Where you get multifocal papillary lesions of the gallbladder?
I don't know if it's papillomatosis or.
Nope, it's ICPN, intraductal cholecystic papillary neoplasm. So it's basically the IPMN of the gallbladder. It's analogous to IPMN of the pancreas or IPNB of the liver. But when it's in the gallbladder, it's called ICPN. So intracholecystic for gallbladder, papillary neoplasm. It's basically very similar to like when you get the IPNB with like all the papillary fronds growing in it. It's completely different than cholesterol polyps, which are benign and have no real malignant potential. The ICPN is pre-malignant, so it ranges from low to high-grade dysplasia. And in this case, this was actually a 4.5 centimeter ICPN with high-grade dysplasia.
Cool.
So yeah, it's cool. I actually teach about this for AIRP, and this was my first, or actually I think my second case that like was my own case. Although I was just reading the follow-up. But then like when I went in the path, it was like 4.5 centimeters and had high-grade dysplasia. So the cool thing is it has a better prognosis than gallbladder cancer, pre-malignant, just like IPMN, can be just high-grade dysplasia. And then we were following it up to make sure that like nothing was involving the liver. Because there was no invasive component, they did not go back and resect segments 4 and 5 of the liver.
Good for the patient.
Yeah.
I have a quick companion case to share if we have time.
Yeah, we have time. Okay, let me stop sharing. Okay, go.
So this is very similar to the peritoneal multicystic case that you showed just now, except it is in this location, right upper quadrant. So young, and they presented with periodic intermittent right upper quadrant pain. So as you can see, there is a lesion which is predominantly fluid-filled, multiple septations, and it kind of insinuates between the structures here. It deforms or it conforms to the surrounding structures. There's no adjacent mass effect. And then this is what it looks like. The thin septations interweaving show some enhancement. And actually, we biopsied this. This was a lymphangioma. We
Wow,
gave
it
the
looks so similar to my case.
yeah, exactly.
Although, you know what, the edges of yours are smoother, like almost like, but no.
But still,
similar.
yeah, how can we distinguish the two, because we
Yeah.
did give the differentials of the same thing. Either this is a lymphangioma or this is a cystic mesothelioma. And that's why they had us biopsy it. So it turned out to be a lymphangioma.
Very cool.
Yeah.
Would you be concerned about, like, say it was a cystic mesothelioma and you biopsy it and now you've spread it? Because remember, it has a high rate of recurrence.
Right. I guess that's one of the concerns. But if it is the benign variant of mesothelioma, I don't know that,
Yeah, it might not make a change outcomes.
it would make a difference. Yeah. And also, I think there was a decision to go to surgery because they were symptomatic. And it's pretty large, this one. So I don't know the follow-up in terms of whether they got everything or do you know if these can locally recur?
I don't know. I know that most of the time we kind of, especially when they look simpler than that one, like we often just like follow them up on MRI or, just call them and they don't really worry about them.
Exactly.
But
cool. If I have a follow-up, I'll let everyone know in the future.
Cool. Okay. Last call. Anyone else have a case? Jonathan, did you pull one up in the meantime?
No, I don't have another interesting one yet.
No worries. Okay, we're going to end early. Have a great week, everyone.
Thanks.
Thank you.
Bye.
Okay, bye.